One of the hot topic in myeloma, we're trying to cover those today, and one of those is MRD. Do I have it? Do I not? Do I bug my doctor for it? Do I not? And when I get it, what do I do with it? And I'm so excited that Dr. Shah was willing to address this topic for us today, and I will turn the time to her to talk about MRD.
Yeah. It's been really wonderful to connect with you all in person and talk in the break as well. So we're going to talk about MRD and myeloma. I know that a lot of you have questions around this, and it is a rapidly evolving field, so we're going to hear a lot in the years to come as well. I think this is... So my disclosures are the same from the morning. And this is the outline of things we'll talk about: myeloma therapies, current and emerging types of biomarkers, the IMWG response criteria when you think about MRD definition, the differences between NGF, which is next-gen flow, and next-gen sequencing, which is NGS, and then in the newly diagnosed myeloma setting, MRD, so a couple of trials I'm going to talk about, and then the maintenance MRD setting, and the maintenance discontinuation setting as well, so trials around those, and then a few examples. So as we know, like myeloma therapies over the last 6 decades have seen a significant improvement, and with that an improvement in survival as well. These are the currently available therapies, and this list is rapidly changing. Teclistamab is probably going to be the next one on it. I wanted to explain or talk a little bit about what is a biomarker, and why I'm bringing this up is because with MRD you will hear the terms predictive biomarker, prognostic biomarker a lot, and to understand what the difference is. So a biomarker is a molecule found in blood or other body fluids and is associated with a condition or disease, and you can follow that to know what the disease is doing. So different kinds of biomarkers would be things like looking at MRD or an imaging study, or the SPEP in the blood with the M spike. So these are different biomarkers. When we think about biomarkers, prognostic biomarkers are ones that if you have a higher level or a lower level, it is associated with the prognosis of the disease, meaning that you know that having this biomarker means there's an increased risk of the disease or a worse outcome or things like that. So we know MRD negativity is that if somebody achieves that, it is prognostic in the sense that it is likely that they will have a longer time in remission or a longer survival if they achieve it. But what about predictive biomarkers? So predictive biomarkers are biomarkers that are associated with response to a particular product or agent. So the first predictive biomarker for myeloma is translocation 1114, where it is able to predict which patients are going to respond to the therapy. And while we need more of that because myeloma can have different subsets and different groups, that's kind of what we're looking at with predictive biomarkers. MRD negativity, yet to be decided whether it is predictive or not in some ways, but I think the field is moving towards understanding that better. These are the IMWG criteria. This paper was from 2016, but I feel like it's a very helpful paper where there are tables. If somebody is truly trying to understand like what their response criteria things are, like it's helpful to look at it. So here I've kind of summarized the findings where you could say like what is the percentage reduction from the baseline, which will tell you if the person is in a VGPR, CR, stringent CR, or things like that. And you have to look at 4 different things. So myeloma is hard in terms of response assessment, not like lymphoma or leukemia, which are a bit easier, I think, in terms of understanding response. And so you're looking at blood, you're looking at urine, bone marrow, and the soft tissue. There are 4 different areas we're looking for disease. When you think about MRD negativity, that is usually a term around the bone marrow and how whether it's cleared from with disease or not, but it also you have to understand what the definition is in the trial you're looking at or what paper you're looking at, because this definition can vary a little bit. But to know what the IMWG criteria definition is that MRD negativity is when you have either a complete response or better. And so only if you achieve the complete response, so you have to have a negative immunofixation, meaning that, the immunofixation in the blood has to be negative before you can even think about whether MRD negativity is there or not in terms of if you're looking at overall response criteria. So just to understand what is the SPEP or the M-spike and immunofixation, you all know like there is the serum protein electrophoresis, and I think, I explain it to patients as if you think about a magnetic field and there's positive charge and negative charge, and you throw all the proteins from the blood into that magnetic field, they are all, each tiny protein is a tiny magnet, and so it's going to move in a certain way. And this spike that you see is how the proteins move. So albumin moves more towards the front of that figure, and towards the right you see is the gamma region, and the gamma region is usually where you see the M spike. So this is kind of how we look at it, and if we see that abnormal spike, we know that there is something going on, and that is a plasma cell disorder state. Similar to that, on the right side is what we call an immunofixation, and with that we are able to tell whether this is what type of protein. Is it an IgG kappa or lambda or things like that? So with this, as you see the band in lane 2 and 6 is IgG and lambda. This is an IgG lambda M spike. So I know this slide is a bit small, but what I wanted to show you is that immunofixations can also now be confusing. So when we think about MRD negativity and all of that, you have to understand, is an immunofixation positive or negative, and look at it with that, because sometimes I have patients come to me very anxious. Oh, the immunofixation is now positive, but is it truly positive? Because it could be DARA effect, it could be immune reconstitution. So those are things that are actually good, and it may not be associated with a detrimental effect. So for instance, in example 1 on the top, it says IgG kappa monoclonal gammopathy, and there's additional oligoclonal bands. So the IgG kappa is the myeloma, so it is immunofixation positive, even though the M spike is 0. But when we talk about the additional oligoclonal bands, that's actually immune reconstitution, and that's not the myeloma. In the second example, you can see it says IgG kappa by immunofixation, and band consists of both M spike and daratumumab. So it's part daratumumab and part myeloma protein. So again, there is some myeloma, and it's IFE positive, as we would call that. And then the third example where it says oligoclonal IgG kappa, this is the example where if we were staging this would be an IFE negative patient, because the patient, even though it says IgG kappa there, it's immunofixation negative, because that oligoclonal means it's not the myeloma clone, it's like an immune reconstitution, which is actually associated with better survival. And so that's one thing to understand. The other thing is immunohistochemistry. So just to give you an understanding, when we stage and we talk about the percentage plasma cells, we're looking at immunohistochemistry, which is an estimate. So when it's 30% or 40%, it's a pathologist looking at the slide and giving their best estimate. They do a lot of this, so they obviously are good at estimating it, but it's not like we're able to truly quantify it. So when you look at bone marrow biopsy immunohistochemistry results, some of the examples here I wanted to show you is that it says, the first example on the right says less than 5% by CD38 immunohistochemistry. So that suggests that there is minimal involvement. And if you go with the IMWG criteria, this would be somebody who is in a complete response, but there is still a little bit of disease there, which is less than 5%. Whereas the bone marrow biopsy on the right top, looking at 60 to 70% is probably a newly diagnosed. But when you see these numbers, you will see many different things that we are talking about. So is it the flow? Is it the aspirate differential? Is it the CD38? But when we're talking about a bone marrow, we're looking at the biopsy CD38 immunohistochemistry usually, and that involvement is what we count as the number for staging and looking at response criteria, not the others. So sometimes I have patients who see like the flow or something and think that, oh, their myeloma is progressing because they see the 95% there or something like that. And then the bottom bone marrow response is no morphologic or immunophenotypic evidence, and that's truly an MRD negative bone marrow, because you can see like there's no evidence even by flow and also by immunohistochemistry. So all MRD negativity is not the same. It's important to look at what the definition the trial is using, the method and the depth. And why I say this is because you can have MRD negativity of 10⁻⁵, so 1 in 100,000 cells, or you could have 1 in a million cells. Those are different states, and as we get better technology, that definition is changing, and it is getting deeper and deeper. So when somebody says they're MRD negative, is it with 1 in 1,000, 1 in 10,000, 1 in 100,000, or 1 in a million? You have to understand what test was done to understand what that actually means. And that's also why I'm saying this is when you read trials, you understand that too. So the IMWG criteria talk about MRD negativity as flow MRD negative, sequencing MRD negative, imaging plus MRD negative, and sustained MRD negative. So these are like the 4 different groups that they put it into. And I'll explain this a little more, but flow is flow-based testing, where it's something called flow cytometry, and my next slide will explain that to you. The next one is sequencing MRD negative, and this is like the ClonoSeq or adaptive that you see sometimes on reports, and that is a different kind of MRD negativity. And the IMWG criteria talks about MRD negativity being 1 in 100,000 cells. So some of our tests are more sensitive than that. And then we look at imaging plus MRD negativity, so MRD by next-gen flow and or next-gen sequencing plus negative PET with a normal SUV. And then sustained MRD is any 2 of these, any method that's seen at 2 time points over more than a year apart, where they are both MRD negative. We consider that a sustained MRD negative state. So when we're thinking about bone marrow aspiration, the bone marrow biopsies where we look at immunohistochemistry or the CD138, but the flow or the bone marrow aspirate is where we can look at the MRD assessment when a patient already has most of their disease under control. So what you can see here is just how flow cytometry is done, but it is a method where the cells, like millions of cells, are put through where the different markers on the surface of the cell are quantified in a way, and this is kind of how the lab looks at it with flow cytometry, and they're able to differentiate different populations of cells as they put all these through a flow cytometer. And when they differentiate the populations, they're able to say like how many of these are plasma cells, how many of these are abnormal plasma cells, and give you a true estimate of the number in that aspirate. So when you interpret bone marrow flow cytometry, sometimes looking at what the type of test is, the limit of detection and sensitivity also helps. The reason I'm saying this is because if you look at the bone marrow on the right, the limit of detection for this test at our center is what I've highlighted in red is 0.0006% of WBCs, provide you have 3 million cells. So part of looking at MRD negative is also having a good sample. If you don't have enough cells in the sample, you can't really estimate MRD negativity. So while you're looking at it, and suppose you got only 1 million cells, and they say you're MRD negative by flow, it's not it mostly might be, but that test is not able to tell you properly whether it's truly MRD negative or not. So for that, you need about 3 million cells, and then you need to look at the limit of detection of it, which I told you that, and if you calculate it, it's about 18 events in the thing. So if there were anything less than 18, we would actually call this an MRD negative patient. If it's anything more than 18, we'd call it MRD positive. So I think in this example, the patient had 14 events in that flow cytometry reading, and so we would, by IMWG criteria or things, and by this flow method, we would actually call them MRD negative. So that's one thing, and then this is the bone marrow aspiration or sequencing by ClonoSeq, where, because this is the FDA approved test, and one of the tests that you will see more universally around is that what they're doing is they identify and quantify the rearranged immunoglobulin H and other receptor gene sequences and find the ID for each patient at baseline. So you do need a baseline sample to really know if you're going to be MRD negative or not, because if you don't have a sample with disease to actually find the ID, you can't search for the ID when there is barely any cells left. So what's the difference between next-gen sequencing and next-gen flow? So I told you flow cytometry, and then I told you sequencing. The difference between them is, sequencing just now, the technology is 1 in a million, so it's a bit more sensitive. Flow, mostly it is 10 to 12 color, and it's about 1 in 100,000 cells. And then you're looking at different things like, because next-gen sequencing is an FDA-approved standardized test, it's national, it is more universal, and it's easier to get at most places. Whereas flow, you have to be at an institution that does flow and is able to actually do this, because not all institutions have the capability to run MRD that way. You need a fresh sample for flow. With next-gen sequencing, you could use a frozen sample, but you do need a baseline sample for that. And so there are differences between these two testings. When you read a study with MRD negativity, it's important to understand what method are they using. MRD is prognostic, like I told you before, and there are many studies showing that in a newly diagnosed setting, in the relapse setting. And this study was interesting when it came out also, because here they're showing you that all these IMWG response criteria, we've been looking at like PR, CR, things like that. Do they make a difference, or is it MRD negativity that's driving it? And you can see that what was significant was all the responses compared to MRD had a much better prognosis compared to all the other response criteria. So I think that's also something to think about, where MRD might be more prognostic than just CR or stringent CR or PR. So I wanted to talk about the Manhattan trial. This trial was DARA-KRD 8 cycles, 41 patients, and the primary endpoint was MRD negativity by next-gen flow in the absence of transplant. So these patients only got 8 cycles of DARA, carfilzomib, Rev, Dex. And this is an example of looking at MRD and MRD negativity in the newly diagnosed setting that had an MRD negativity rate of 71%. Now we're seeing more studies using MRD negativity as a primary endpoint. So this is the phase 3 GMMG HD7 that was run mainly in Europe. And it's the first phase 3 trial with a primary endpoint of MRD negativity. And isatuximab, Revlimid, Velcade, dexamethasone was the regimen used in the study. So while in the US we tend to use more of the DARA, RVD upfront based on the Griffin trial results, the Griffin trial is not a phase 3 study, it's a smaller study. The isatuximab is actually a phase 3 study that met its primary endpoint of showing higher MRD negativity, and that was recently presented at ASH last year. So the challenge with isatuximab, it's mainly IV, and so DARA has the sub-Q option, which makes it easier to give patients. So the master trial, I think you all must have heard a lot about this study, and this is one of the first response-adapted designs to achieve MRD negativity, meaning they're looking at it as, can it be predictive as a biomarker, and can we drive and make decisions around therapy with MRD negativity in mind? And so what you can see here in this study is that they did 4 cycles of a quadruplet, daratumumab, carfilzomib, Revlimid, dexamethasone. Then they did a transplant, and at each of these times where you see the yellow stars is the MRD assessment, and they use next-gen sequencing. I think they use the adaptive ClonoSeq method. When the patient finished the transplant and they had testing, as long as they had 2 time points, 2 of these yellow stars basically that were MRD negative, they reached what they call the MRD shore period, meaning that now they don't need any more treatment because they have 2 time points where they were MRD negative. That doesn't mean they were sustained MRD negative, because those time points are not more than 1 year apart. They were just MRD negative at 2 time points, at which time they go to the MRD shore period, which is treatment-free observation. And if they were not MRD negative, they would get 4 more cycles and then test again. And if they reached that, then they would go to observation. If they didn't, then 4 more cycles. And those who never got to MRD negative just stayed on lenalidomide maintenance. So, and they followed patients who went into this MRD shore state with looking at every 8 weeks for 24 weeks, and then every 16 weeks after, they did MRD assessments. And so it was basically like annual MRD assessments after, and they encouraged people to stay on that even after the study was over. What they saw was what you can see here is that the first two bars, like the blue and red, is post-induction, then it's post-transplant, and then MRD directed consolidation if they had. You can see that MRD negativity did improve with more cycles or more treatment with each group. The blue and red is just different MRD assessments. Sorry that it's a bit small. And what is interesting is also, like, the first group is all patients, and then they're looking at 0 high-risk cytogenetic abnormalities, 1 and 2 plus. And those who had more than 2 high-risk cytogenetic abnormalities, I think what's interesting is that they had less MRD negativity based on, like, this study, and the percent. And if you see the graph on the right at the bottom, you can see that with each different therapy, there were more patients reaching this MRD negativity state. What they did show was the PFS, or the progression-free survival, for patients who had 0 or 1 high-risk cytogenetic abnormality was not any different at about 30 months, but those who had 2 high-risk tended to progress or have a different progression-free survival. However, with looking at MRD negativity state, all those who achieved it, the ones who had the MRD more than 1 in a million, which is the green bar, seem to be a little bit better than the others, but it's not statistically significant. I also think it could be related to the short follow-up, and we need to see what that looks like. So that's the master study where, they are trying to now bring this in, where we are actually deciding how much therapy a patient gets dependent on their MRD status. So MRD negativity on lenalidomide maintenance, this is a study from MSK where we had about 108 patients at MSK on lenalidomide maintenance. They were grouped into 3 different groups: those who are sustained MRD negative, meaning no evidence of disease, at every time point. Those who lost MRD negativity means they reached MRD negativity, but they were no longer MRD negative at some time point after, or they were persistent MRD positive. And I think what's most interesting is that those who lost MRD negative did worse than those who were persistent MRD positive in this study. So what it goes to say is that it's not just the effect of the myeloma, but there may be something to do with the microenvironment or things like that as well. Then why do some patients, we're never able to get them to an MRD negative state, but they still do well because their disease just stays at this low level, persistent. And there are some and that disease doesn't seem to increase, it just stays at that small level. And why are some patients going into this MRD negative state and then the disease coming back? And I think that's what we need to understand more about when we think about MRD negativity. So this is the dramatic study that Dr. Savaro was talking about earlier. This is the study where the primary objective of the trial is to compare overall survival between the 2 treatment arms, lenalidomide versus lenalidomide and daratumumab. And what they're doing in this study is trying to understand the effect on overall survival with doublet maintenance versus single drug, but also adapting it to an MRD design where only if a patient is MRD positive will they need more therapy and continue on it. And if they reach MRD negativity, they're actually randomizing them to continue this maintenance versus stopping it and seeing what happens over time. And the study is going to go on for, I think, about 7 years for patients. So while the study started a few years ago, it's 74% enrolled, I think, based on what I saw on the SWOG website. But I think that it'll take a few more years for us to see early data. But if we want to really see what happens, since this is an overall survival endpoint, it's going to take some time to find actual results with that. And then what about maintenance discontinuation? This is a question, again, that we all talk about a lot of, like, should we stop or should we not? And we have 2 studies that I'm aware of. There might be more going on, but there is one at MSK where we are looking at 50 patients, and the therapy duration before discontinuation should be 3 years from start of maintenance. And these patients should be on should have sustained MRD negativity at 2 time points more than 3 years apart. So while they're MRD negative not just one time point, but they're going to be 2 time points, and those it's not 1 year apart or 2 years. It has to be 3 or more years apart that we have to document sustained MRD negativity, and then the patient should be interested in going on the study, and then they will be stopped from all maintenance and followed with bone marrows every 6 months to see are they losing the MRD negativity and what's happening with that. With this study, it's going to be the MRD positivity definition is around the next-gen flow definition. There's one study at University of Chicago where they're doing a similar kind of stopping lenalidomide or whatever the maintenance is. It's not only lenalidomide, it could be any maintenance, actually for both the studies. But what they're doing is they're saying that they can stop therapy 1 year, 1 year of therapy from start of induction. So these patients, if they reached MRD negativity 6 months post-induction, because they might have got 6 months of induction and 6 months of maintenance, they can stop on this study. But that means that they're stopping not even at 2 years, but they're stopping earlier on. So I think both these studies are kind of different, but kind of trying to ask the same question in different ways. So they will give us complementary and interesting data to see. And they're looking at MRD negative at enrollment and then completed 1 year. So I just wanted to show you some examples. This is a patient of mine with non-secretory myeloma and had evidence of like cytopenias when they were diagnosed, and that's how when a bone marrow showed that they had about 80% involvement, but there was no myeloma protein in the blood. This was a standard risk ISS stage non-secretory myeloma. We treated with initially RVD, however, because of issues, we switched over to DRD, but managing patients with non-secretory myeloma can be very tough because we are not able to see their blood responses. We have to do bone marrows at each time. So when we did a repeat bone marrow, there was a drop in the plasma cells from 80% to 40%. So there was some response, and but we saw this translocation 11-14 at that time. However, while they were still on the treatment, they developed fevers, and we could not figure why, because it seemed like they were responding to treatment. A lot of workup done, nothing was found, so we decided to repeat the bone marrow, and actually the patient had continued to respond, it seemed, on that bone marrow. So we thought, like, okay, we should still continue the treatment. They're responding. However, at that time, there was on genome sequencing, we saw a P53 mutation. However, the fevers continued. There was severe fatigue. So we repeated a bone marrow again because we're like, we don't know what's going on. And this bone marrow actually had 80%. So some of it is when we talk about this MRD criteria and we talk about response, it's also looking at did we get an adequate sample? So the one that we got at that time where it was 10 to 15, it could have been an issue with an adequate sample and also patchy distribution of disease or things like that where the fevers are probably myeloma fevers. So these are tumor fevers is what we found eventually because as the disease came into remission, the fevers stopped. So this was basically now high-risk myeloma with a 17p deletion. So we did end up doing DSTEP and some of these other treatments. However, the treatments didn't work that well where the myeloma came down from 80% to 40%, but really DSTEP didn't bring it down as much. So we ended up switching to venetoclax because of this translocation 11-14 that we had seen on a previous bone marrow. And 2 months later, when we did a bone marrow biopsy, it was in a complete remission, a complete response, stringent complete response with flow MRD negativity. We're not managed to achieve this with any other treatment for this patient, but with this treatment. So I think that this predictive biomarker tells you that looking at some of these things where you have to do bone marrow sometimes at relapse or things to see if the translocation 11-14 is there, not because mostly these translocation 11-14s developed at baseline. They're not new at relapse, but sometimes maybe the testing that was done was not good to detect it or things like that, and we may have found it because the first bone marrow, the patient didn't have it, and I think that was just a consequence of where the testing was done and it wasn't found, it wasn't at our site. So other clinical scenarios to think about is like, when we think about MRD and areas of debate, and I don't think I have answers for you, but questions where a newly diagnosed patient achieves MRD negativity with induction therapy, should you transplant? And I think this is a common question patients ask. We're asking if patients go to different myeloma doctors, you're going to get different answers because every doctor looks at the data a little differently in terms of what they're focusing on. So I think that this is an area of open debate and questions, but what I tend to do is I think we need to now start thinking about individualizing treatment to patients instead of thinking about one size fits all. So we do talk about transplant, and if they've achieved MRD negativity, while I do say that transplant should be a part of your treatment at some point, if a patient's reached this and they want to delay it to the first relapse, we have that discussion, knowing that that may be something that not everybody agrees with, but I think if a patient really wants to do the transplant upfront, I'm not against it because I think that the data is mainly for upfront. But some of the studies, like the Determination trial and other trials, have shown that as long as you get a transplant either in the beginning or at first relapse, the overall survival doesn't change. But the counter to that, which many people bring up, is that not everybody gets to the transplant when they reach the first relapse, so should we just do it in the beginning? And I think having patients understand that and decide, can be helpful. The next question is relapse patient that does not achieve MRD negativity, should you escalate therapy? And I have patients ask me this all the time, is that, patients who are reading and quite educated about myeloma therapies, they'll say like, I've had this M spike for years now, but I'm hearing all this data about MRD negativity. Should we add some new drug so that we can get rid of that last M spike that's there? But my answer to that is like, if things are working and it's stable, like I wouldn't change anything at this time and just continue the therapy even though they've not achieved MRD negativity, because we know myeloma is a marathon and not a sprint in terms of using the different therapies over time. So I wouldn't want to use all the therapies up front to try to just achieve that MRD negativity with not save things for later. And then patients in sustained MRD negative has significant side effects and that are impairing quality of life on maintenance therapy. Should you stop at that time? And again, I think this is subjective. Would the patient get very anxious to stop the therapy, or would they actually feel better and have better quality of life? So I think this needs to be, again, a discussion with patients. But I think that if patients have been many years on Revlimid and starting to see like diarrhea-related issues or fatigue issues or other quality of life, then this could be a discussion that you're now sustained MRD for so long, will follow you closely and consider stopping it, although we don't have clinical trials, again, around that. So with that, I'll conclude that MRD definition is evolving over time. New technologies being developed and established methods are being improved to be more sensitive. So while we can say that MRD negativity is good, what is MRD negativity? That definition is changing. Retrospective studies and clinical trial meta-analyses have shown it is prognostic, but we have limited data on prospective studies of escalation or de-escalation of therapy based on MRD negativity. Therefore, it is not yet predictive. It is unclear if sustained MRD means cure in a subset of patients. If MRD is used as an endpoint, this could lead to faster regulatory approvals because you're not waiting till the PFS reads out or the OS reads out. And I think some of that is, if we know that MRD negativity is truly matches or correlates with PFS, then you could use that as a quicker endpoint to get approvals and move trials faster. And can and should we use MRD to guide decision-making in clinical practice at this time is debatable. And again, you will see a lot of myeloma doctors saying one way or the other. I think that one size doesn't fit all, and take patient choices and symptoms into consideration based on MRD results and then think about it. So with that, I will end, and thank you.
Oh, wow, that was jam-packed, and you gave us so much good information. I really appreciated your recommendations on those clinical scenarios.